our NNF Karnataka e-masterclass, Learn from the Master itself. So today we have got two most important and most interesting topics. One is interpretation of the lab reports, especially in sepsis. And we have followed by that, we have a talk on normal anatomy, ultrasound anatomy, and the normal views which we need to, important to take when you're doing the scans, ultrasound scans, which has become a vital part and the most important part in our day-to-day management in NICU. So today we have got two wonderful speakers. One is Dr. PARIMALA. She is consultant neonatologist at Aster CMI Hospital, Bangalore. And we have Dr. Nandini Nagar, followed by her talk. She's the chief neonatologist at Cognate Group of Hospitals, Jayanagar. So today, we would like to give a warm welcome on behalf of NNF Karnataka chapter from our entire NNF Karnataka office, President, Vice President, our Joint Secretaries, Executive Board members. A warm welcome to you, Dr. Parimala.
Thank you very much, Dr. Prashant, and good evening, everyone. I really thank NNF for this great opportunity. Let's start with lab reports interpretation in sepsis. I don't know who thought about this reading between lines. I hope I do justice to that topic. So before I start, I would like to say one thing. No matter how much of our investigations I'm going to show you and how many of our lab results we are going to get, ultimately sepsis, the diagnosis is based on the clinician. So if the clinician strongly suspects sepsis, it is sepsis actually, unless proven otherwise. So it is a clinical diagnosis, and all the are going to be only supportive evidence, and unless we get a gold standard diagnosis through cultures.
Ma'am, please unmute yourself, ma'am.
Okay. As I said, sepsis is a clinical diagnosis, and the laboratory test what we do are only supportive evidence. So ultimately, if the clinician feels it is sepsis, it is going to be sepsis. So these lab reports, because we have plenty of results, so how to classify them and how to group them would be an interesting thing to think about. So what I thought was we would first see what are the stages of sepsis. So normally there are 3 stages of sepsis, as we all know. So one is just sepsis, which means just there is bacteremia or viremia or fungemia in the baby's blood. And because of that, whatever reaction happens in the baby's body, it might be the anti-inflammatory reaction or inflammatory reaction. So that constitutes sepsis. And the second stage is a severe sepsis, where there is sepsis plus at least one organ failure, any organ. And septic shock, as we all know, the baby is in shock. So the types of sepsis can be either bacterial, viral, or fungal. And parasitic sepsis, somehow we don't call it sepsis, but parasitemia. So these are the main 3 types of sepsis which we are trying to look at. So our investigations are going to be based on this. So when we do lab investigation, we'll have 2 objectives. So one is to confirm sepsis. The other one is to assess the effect of sepsis on the baby. So confirmation of sepsis would aim at finding the pathogen itself, either the virus, bacteria, or the fungus in the baby's body, or the baby's reaction to these pathogens. So that would all come under confirming sepsis. So there would be one group of tests which I'll be first discussing, which we commonly do, that is to confirm the sepsis or to assess the prognosis. But the second group of tests, what I'm going to talk about, will be assessing the effect of sepsis on the organs. So suppose if the sepsis is causing poor perfusion, so we will be looking at an indirect evidence of elevated lactate, whereby it shows that the perfusion is poor, and indirectly we assume it is because of sepsis. So those tests which look at the effect of sepsis on different organs would be grouped together. And those tests which are going to confirm directly as there is sepsis in the baby's body would be grouped as one group. This is just to simplify. So let us start with the commonest test we do for neonatal sepsis. And before I go and show you all the numbers which I'm going to show in these slides, I would like to say that whatever numbers I've taken as a main thing to indicate sepsis are all belonging to the majority of people what they've agreed, because when I say complete blood count of less than 2000 or more than 20,000, there are quite a few evidence which says even more than 20,000 it is not indicative of sepsis, and there are some evidence which says even less than 2000 is not indicative of sepsis, but it has to be less than 1500. So they are outliers. So I've taken the levels just to simplify. They've taken the levels which are agreed by majority of people and majority of studies. So when we start with lab test for sepsis, first thing we do is complete blood count. Complete blood count just to see how the baby is responding to sepsis. As we all know, neonates can either mount a response or completely not mount a response. So which means they can be neutropenic or they can be they can have high leukocyte count or low leukocyte count. So the total count can be high, elevated more than 20,000, or it can be less than 2,000. So both are suggestive of sepsis, out of which less than 2,000 is more significant. Neutropenia is more significant in neonatal sepsis as compared to older children, where leukocytosis is more significant. So after complete blood count, we come to the differentials. When we differentiate and see, we all know that usually babies will have predominant lymphocytes. So 60 to 70% of the cells would usually be lymphocytes. But on the contrary, if you're finding more of polymorphs, so if you're seeing more than 60% of neutrophils in place of lymphocytes, that is one indication of neonatal sepsis. So this is all we are reading between the lines, because we know that what is normal. So this doesn't look normal. So kind of we are thinking probably this would suggest that there is sepsis. The next one is absolute neutrophil count. So out of all the cells, we are going to count only the neutrophils, and as compared to the total actually. So this absolute neutrophil count, if it is less than 1800, again it is suggestive of sepsis. As I said previously, there are quite a few evidence which says it has to be less than 1500, but this is a commonly agreed number, so I put at 1800. And next would be band neutrophil ratio. So where we all started, I think back, this has never gone out of fashion. So right from long back till now, band neutrophil ratios stays as one of the prominent indicator of neonatal sepsis. When we say band neutrophil ratio, the immature neutrophils, all the granules, everything is aggregated, so it looks like a band when you see under microscope. And the mature neutrophils, as we all know, the granules are segregated, so we can differentiate them. So if we count the number of bands and divide by the mature neutrophils, that ratio is called band neutrophil ratio, or IT ratio. I stands for immature cells and T for total cells. So this ratio has to be more than 0.2 or more than 20%, which means there is sepsis. Because there is sepsis, there is little bit of bone marrow suppression. So baby is trying to fight, so it's going to produce more and more immature cells. So that if it is exceeding more than 20%, so it's an indirect evidence of sepsis. And CRP, as we all know, it's not a diagnostic marker, but definitely included in all septic screening and screening for suspected sepsis. So this CRP again depends on the lab values. So there are values in some labs which says more than 0.2 as significant, and there are some labs which has 20 as a cutoff because it is into 10 actually, and there are some values which has 6 as a cutoff. So depending on our lab, this would be the significant value. Anything more than the normal value would show that the CRP is raised, which means baby might be having sepsis. Again, as we all know, newborn babies are not going to mount CRP response in less than 12 hours actually. So we have other things, newer tests, which I'll be discussing later, which starts before CRP and then goes away once the CRP starts rising. So CRP is used more as a prognostic tool, because we know that the first level is so much, and then after 24 hours you see the CRP. Okay, but then the next day it looks like 0.3. That means there's a slow rise, indicates sepsis. So it is more used for prognosis, or to look back and say whether there is sepsis or not, looking at the rising trend or decreasing trend, rather than just as a single test to say whether there is sepsis or not. In this case, we have the procalcitonin. It's the same kind of precursor of the calcitonin produced in the C cells of parathyroid, and this levels are little higher in case of sepsis. This produce more in case of sepsis. So normal levels, more than 1 itself is significant. Again, as I said, more than 4 is 100% kind of confirmatory about sepsis. More than 1 or 1 to 2 is kind of significant. More than 2 is reasonably taken as sepsis. Again, procalcitonin, it does not get influenced by other factors. Suppose CRP, if we take, if the baby is born with meconium aspiration or baby is hypoxic, baby has HIE, there are other things, poor perfusion, other things which can also elevate the CRP, or the baby received steroids, mother had antenatal steroid just before delivery and baby is just born. So these are the things which are going to influence the CRP levels, unlike procalcitonin, which doesn't get influenced by this one. So that way, that is more significant compared to CRP. And also in surgical babies, so post-surgery, always because of tissue damage, CRP is going to be high. So we do not know if the CRP is high because of post-surgery or because the baby has a post-surgical infection. So those places, procalcitonin is more useful compared to CRP. We do have presepsin, which I'll discuss a bit later. But that also is more significant than procalcitonin and CRP. It's newly coming into a picture. So a presepsin level of less than 500 picogram per ml is also suggestive of sepsis. Apart from this are old things which we used to do even till now, which is kind of having a high yield, is a gastric aspirate. So if the newborn baby generally should not have any pus cells in the stomach. So if you do a gastric aspirate and if you're seeing more than 5 polymorphs in the stomach, that indicates probably an infection in the baby. That shows that probably mother had some infection, maybe leaking PV, but she also had an infection. So the bacteria has gone into the baby. So we are aspirating, and when we check, if you see the leukocytes, it's suggestive. Micro ASR is also a good indicator. So if it is more than 15 millimeter, it is significant. But always in the past, now and in the future, probably always the gold standard is going to be the culture. So the gold standard is going to be the culture. So either blood culture, urine culture, or CSF culture, if that is going to grow organism, so that is the gold standard of sepsis. So that is a confirmatory test for sepsis as well. And apart from this, if it is a newborn baby or just born, then these are okay. But if the baby has been with us for some time and still we want to see, like suddenly the baby is deteriorating and we are suspecting sepsis, then there are few other things we can do, cultures apart from the blood, urine and CSF, which also if it grows something would suggest sepsis strongly. So these would be all the secretions. So secretions means if the baby is having a lot of secretions from the ET tube, we can send that for culture. So if it is kind of positive, we know that there is infection. The lines like umbilical catheters or its long line, any lines in the baby, that tip can be sent for culture. And endotracheal tube tip itself, strongly suspect. The catheters like urinary catheters and other catheters, nephrostomy tubes, drains if it is a post, or chest drains if the baby is on long-term kind of pleural drainage or peritoneal drainage. So these ones also, when we are suspecting sepsis, we can send either the secretion or the tip itself, we can remove and send. And if it is kind of growing a bacteria or virus or fungus, then we know that there is sepsis. So the newer method of confirming this is if we do not have enough samples. So whenever the blood culture, we know that it less than 50% of the time it comes positive, though it is gold standard. So what do we do in the remaining 50% of the time? And if you want definitely some kind of confirmation that we are dealing with sepsis only and nothing else, then we can go for the rapid PCR test, which also is going to identify the antigens. So it is going to identify the pathogen, the pathogen. So part of it. So if fragment is enough, so we do not need a large amount of sample, and a small fragment, very sample, they can detect the all the current situation, including the COVID and parasitic tests as well. So this can be done by rapid PCR test, which can detect these cells in minute quantity. And if it is, and this also is confirmatory test for sepsis. Apart from this, we also have antibody test. So we know that IgM and IgG are the commonly used antibodies we check for. And to simplify everything, if only IgM is positive, it's a current infection. If only IgG is positive, it's a past infection. So the baby is not infected as of now. If both are positive, it is still current infection and baby is trying to fight the infection and mount a response. Apart from this, we can look for, if we strongly suspect fungal sepsis, urine for fungal hyphae would be a better kind of test to do rather than blood, because unless it's a very florid sepsis, blood may not grow fungus that much. So urine fungal hyphae, if it is there, that could be suggestive of sepsis. We can also look for nasopharyngeal aspirates and swabs when we are suspecting viral infections, viral sepsis. So including swine flu and other viruses and even corona. So we can send this swabs when we're suspecting. So these are all kind of confirmatory tests, because as initially I grouped, we have initially what I said, like we have the test which can confirm or the presence of pathogen in the blood or the body's response to the pathogen. So these are all trying to be the confirmatory test for sepsis. The next group which I'm going to discuss now are going to see the effect of sepsis on the baby. So there is sepsis maybe, but then we do not know whether it is there or not, but we look at the effect, what it does on the perfusion, what it does on the other systems of the body. And if it is all affected, then we think probably it is because of sepsis. So these are all indirect evidence of sepsis, not direct like what we saw in the first two slides. So now we are going to see the indirect evidence. In indirect evidence, the first and foremost thing would be the blood lactate levels. Again, blood lactate more than 1 is significant, as I already said, but more than 2 is taken to be more strongly significant. More than 4, definitely probably the baby is in septic shock. So anything between 1 to 4 is positive. So if the lactate is high, and if you're doing a gas and seeing a lot of metabolic acidosis, then we do know that there is some perfusion problem. So this is one of the effect of sepsis, not sepsis itself. So because of low perfusion, anaerobic metabolism is high, so the acids are increasing in the body, and that is causing the high lactate level. So that is what we are looking at. And then we go for thrombocytopenia, where the platelets are less than 1.5 lakhs. Again, as I previously said, this is not that one number which we can stick on to. There are studies which shows like the newborn babies can have platelets as low as 85,000 or above. But then this is the most common kind of accepted number. So I put as 1.5 lakh. If you see thrombocytopenia and then you do coagulation test and you see that there is elevated PT, PTT, and we check for D dimers, they are also elevated. Fibrinogen is there. That means there is some microthrombi, there is some DIC happening in the baby's body. So we know that probably it is because of sepsis. So this is again effect of sepsis. So these are also indirect evidence of infection. We check the renal profile and we see that there is a renal shutdown. So we see acute renal failure or pyelonephritis causing elevated urea, creatinine in the baby, and with clinical symptoms, of course. So if you see that kind of thing, then again we can suspect as an indirect evidence. So we will check the liver function test. You see more of conjugated bilirubinemia, though unconjugated also can happen in sepsis. Conjugated is a little common, so it's more towards sepsis, but not in the severe range like biliary atresia, but then definitely there is slight elevation of conjugated fraction. That occurs in septicemia. Also, if you see elevated enzyme, that can be secondary to neonatal hepatitis, again part of infection. So it can be bacterial, viral again. So these are also suggestive of sepsis. So other effects which we can look in is the glucose level, because the bacteria itself might be using, so there may be hypoglycemia because it might be using as a substrate, or there can be hyperglycemia because of sepsis. There is a lot of stress. Stress hormones are high in the baby's body. So you can see either one of them. Again, it's an indirect evidence. The other evidences we look for is the imaging. So in the imaging, we can do a chest X-ray and find out congenital pneumonia. We can do an abdominal X-ray if we're strongly suspecting NEC, but we're not getting any evidence pointing towards there. Or we can do ultrasound. Ultrasound, we can do neurosonogram, or we can do ultrasound chest if you're suspecting strongly either pneumonia or effusion, abdomen to look for pyelonephritis, abscess, other foci. So these all would give us also an indication. Echo also has become a part of evaluation of sepsis now. If the center is equipped with echo, it's better to use it, because we do see ejection fraction becoming lower and lower. So before baby goes into septic shock, we can kind of hold them and we know whether it is high volume or low volume. So looking at the cardiac output, we can decide whether we are overloading the baby with fluid or whether we are underdoing that. So echo is helpful in that, and also to diagnose as an indirect evidence of sepsis. So even myocarditis, we can look at the function of the baby, the function of the cardiac muscle. So in current corona, viral myocarditis might be the presentation in the newborns. If they're getting very sick, very rapidly kind of collapsing, so we should always think of viral myocarditis when there is no RDS, no other reasons for doing that. So echo would be useful there. CT also is useful, but as a last resort if you don't get any answer. So imaging also plays a part in sepsis. The newer test because I'm happy that I passed my PG before all this came into picture, but then we need to know because we are still practicing and kind of these are all available. So if the finance is not a constraint and all this test, the lab has all this test at your at your disposal, then I think we need to know these are the other tests which we can do if we don't get any evidence from the previous tests what we so far have done. So these are the other tests which are available to us, which also can show you whether there is sepsis or not. One is SAA or serum amyloid A, it is called as. So this serum amyloid A is usually produced in the liver, endothelium and monocytes, also smooth muscles. This is regulated by the interleukin 1 and interleukin 6 and also TNF alpha. So this, if it is elevated, this is also an indirect evidence of sepsis. The lipopolysaccharide binding protein or LPB, this has come into vogue now, and this is very, very sensitive to gram-negative sepsis. When we are strongly suspecting gram-negative sepsis, we can look at this if we don't have any other evidence, because the endotoxin which is produced by the gram-negative bacteria, to bind to the CD14, it needs this receptor, that is lipopolysaccharide binding protein receptor, so which is produced from the liver, muscle and epithelium. So if you find lots of this, that means we know that gram-negative bacteria is there in the body and it has produced the endotoxin and there is sepsis. So the next other things are alpha-1 antitrypsin, fibronectin, haptoglobulin, lactoferrin and neopeptin. So these are all elevated in sepsis except for fibronectin. Fibronectin will be reduced in sepsis. Normally, normal levels would be, if it is 1 to 10, it would be less in neonatal sepsis. So the other test which we are looking at and which is going to cause the maximum problem in sepsis. So we know that sepsis can actually trouble the baby either directly by the infection itself or by the inflammatory mediators which are produced by the baby itself. So it is more like an autoimmune phenomenon. So once once it starts rolling, we are not able to stop it. So we are having more of disorders, multi-organ dysfunction, everything, not because of the infection as such. Infection has already happened. The cytokines are, the endotoxin has come or exotoxin has come and the cytokines are already stimulated. After that, we are not able to stop it. So how do we confirm it? How do we confirm that this cytokine storm has started to happen because of sepsis? So that we can look into by newer tests. So we have, before we go for what are the tests, I thought I'll just give a background of how this works, how the cytokine works and how the chemokine work. So normally we have two of them. One is cytokine, one is chemokine. As the name suggests, one is stimulated by the chemicals, the chemokines, and other is stimulated by the cells itself actually, which is cytokines. So how they work is, whenever there is infection, what happens is the receptors which are going to bind to these pathogens are getting activated. So which are the commonest receptors? Why I'm mentioning is these are all, now we can identify these receptors. We've gone to that level of molecular biology now that we can pick up this and say that yes, these receptors are high, so the baby may be having sepsis. So these are the three main ones actually. So one is TLR or toll-like receptors. The other one is nucleotide binding oligomerization domain-like receptors. NBO, DMR, that is retinoic acid inducible protein like receptors. So all these receptors gets activated whenever there is infection. So once the receptors are activated, they go to this TH cells, and TH cells are two types. We have TH1 and we have thymus cells 2, that is TH2. So the one is always stimulatory in effect, the two is anti-inflammatory in effect. So both are useful in sepsis. So the TH1 stimulates the whole cytokine cascade, the whole cascade of inflammation. So once that is stimulated only, we are going to fight the infection. The baby is going to fight the infection, but at the same time, it has to stop at some point. So that happens with the TH2 or the anti-inflammatory cells. So that once the infection is over, again, the self-destruction is kind of prevented by stimulating the anti-inflammatory cells. So now again, as I said, newer tests can measure the stimulatory cells as well and anti-inflammatory cells, the levels in the body. So based on that, we can say in what stage of sepsis the baby is in. So once the stimulatory cells are stimulated, what happens? Once it's stimulated, naturally the pro-inflammatory cytokines are released because they are stimulatory, which are nothing but the interferon gamma, TNF alpha, IP10, IL2, IL6, IL8, IL12 and IL17. So these are all the pro-inflammatory cells. So if you're finding elevation of any one of them in your body, in the baby's body. That means the sepsis process is on and the inflammatory cascade has been stimulated and the baby is actively fighting the infection. So the next set of cells it stimulates it. So the first set is a pro-inflammatory. The next one has a mixed function. So it is called multifunction cytokine. So both inflammation also happens and anti-inflammation also happens. So it has multifunction. Because inflammation is not the only function they do, these cells, they also have other functions in our body, which we won't be discussing because we're limiting towards sepsis. So the multifunction cytokine, or mainly what are they are this interleukin 1 beta, the MCP or monocyte chemoattractant protein, the soluble CD40 ligand, and IL-3 and growth factors along with GCSF. So this is where our GCSF come into picture, because in severe sepsis we try to give GCSF. This is how it's going to act. So once these things are high in the body, what happens is they release the secondary mediators. Secondary mediators are our nitrous oxide, thromboxane, leukotriene, PAF and prostaglandins, apart from complements. So once the secondary mediators are activated, they are going to activate the further pathways, either coagulation pathway, which is going to cause DIC, microthrombi, clot, which is what we found out by checking our PT, PTT levels and fibrinogen, D dimers and all that. Or it can activate the complement cascade, which also causes damage in the body, and or it can produce prostaglandin or proteases and oxidants. So why this is important is, in a minor quantity, it is okay. It is going to kill only the pathogen and the endotoxins. But if it is activated and it's uncontrollably just going on, it can damage the cell tissues as well. So the baby will be in a kind of roller coaster ride of either SIRS, systemic inflammatory response system syndrome, or DIC, uncontrollable coagulation and bleeding secondary to that, consumption coagulopathy, or MODS, multi-organ dysfunction system syndrome, or complement activated response. So all of this are going to actually worsen the sepsis, because the initial infection is now gone. So why we need to know this is, at this point antibiotics are not going to be of any help, because the bacterial pathogen as such is not circulating there, that has been killed, but whatever it is produced and what the system has activated, that is going to be in full-blown activation now. So if we know, if we can catch the baby at this point, we can still use steroids and other anti-inflammatory drug to reduce the damage which this is going to cause. So the other newer test of sepsis, because we know now which are the pro-inflammatory one, which are the anti-inflammatory one. Now we understand better, like when I'm saying like we are going to check for IL-6. If you're going to check for IL-6, we automatically think, okay, that's one of the pro-inflammatory cytokine. So they're produced from both. It's produced both from B cells and T cells, and it acts on the liver. And once it acts on the liver, then CRP is produced. Why I'm stressing on this is, I told you the very first day when we check CRP, it's not going to be positive. That's because first the pathogen has to sensitize, then this interleukin 6 has to be released. This has to activate, this has to be produced from the B and T cells of the baby, go to the liver, then only CRP will be produced. So not what happens if you check the interleukin level, within 6 hours if you check, it is going to be maximally high in a baby who has infection, which is born with infection. But it disappears in 24 hours, because after that the CRP starts rising, then the job of the interleukin 6 is done then. So if you want to diagnose sepsis within first 24 hours, when you cannot rely on CRP, that is where this would come into picture. If you go to interleukin 8, it is still more faster than 6, because this is the only one which is produced from chemokine, as I said, not from cytokine. So this causes the leukocyte migration and activation. So this peaks within 2 to 4 hours itself. So within 2 hours, if you check, and within 4 hours we have to check, because after 4 hours this disappears. So checking after 4 hours, this is of no value if you're doing interleukin 8. So these two are important, because if you're faced with a baby which is going downhill very fast, and we don't know if it is something is sepsis or something else, if we can get IL-6 and IL-8 level, so that kind of takes you towards the track, whether we are on the right track or not. So the other cytokines are anti-inflammatory cytokines, which I told you about. So there are only 2 anti-inflammatory cytokines. One is IL-10 and the other one is transforming growth factor beta.
Hello. Hello, ma'am.
This is Nandini's husband speaking. So I'm just configuring it. It's configured now on her laptop. Yeah, she's
Dr.
here.
Parimala, kindly unmute. Yeah, Dr. Parimala, kindly unmute and continue the presentation. Dr. Parimala?
Sir, exit ಆಗ್ಬಿಟ್ಟು here. 1 second. Sorry.
Am I audible?
Yes, ma'am.
Yes, please continue presentation.
Fine. So we were talking about anti-inflammatory cytokines. So if you have an elevated IL-10 and TNF alpha ratio, that is useful to find out if the baby has already crossed the cliff and has come to the recovery kind of side. And it's also useful in late onset sepsis. So the last but not the least is our omics. So omics is just the in thing, just like our coding, which is coming in now, and literally every child should know coding. So just like that, every one of us should know omics as well. What are these omics? These omics, there are 3 of them. So one, we have genomics, we have proteomics, and we have metabolomics actually. So when we say genomics, that means what all tests we have which are related to genetics, that is called genomics. If we can do any tests which are related to identification or separation of proteins in the body, like even CRP is a protein, so alpha-1 antitrypsin is a protein. So any such proteins, if you can separate them and assess them and say that, use it as an evidence of sepsis, that is called proteomics. And the metabolomics is to see the metabolism. So if you can measure the metabolism in some way, and if you can use it as an indicator of sepsis, that particular study is called metabolomics. So we'll start with genomics. So genomics is nothing but our gene detection. So PCRs would come under genomics. Our PCR rapid tests will come under genomics. And if you can, suppose I said like we are checking for IL-6, IL-8 like that, interleukin. But if you can find the gene itself, which is going to code for the interleukin, if you can identify that and measure that. So we've gone so far now. So if you can do that, that is genomics, and that gives you rapid results. Even within minutes, maybe we will be able to diagnose sepsis. This is for the future, current and future probably. Proteomics, we are already using most of it, like our fish and all that. So we are separating the protein, measuring it, and quantifying it to say whether there is any indication of sepsis or not. In metabolomics, we are measuring the metabolism, like the nuclear MRI, PET, even mass spectrometry. So all this fall under metabolomics. So now, when are we going to read between the lines? I told you all the lines now. So you know what is sepsis, what is not sepsis. So what level would be kind of confident for you to be confident to say that maybe baby has sepsis or maybe baby doesn't. So, but it is never clear cut. As neonatologists, we all know that we just know that the baby is off, and we do not get anything to support, we suspect sepsis, but then most of the times we do not get anything which will add up or anything to say that yes, it is sepsis. Though we have all these newer tests, we still cannot be 100% conclusive, as I said. And all the gold standard tests are less than 50% sensitive, 50% only will be positive. So then we end up reading between the lines actually. So how do we read between the lines? Whenever things don't add up. So we get a normal CBC, normal CRP, normal culture, but then baby is not taking feeds, is looking lethargic, and we know that baby doesn't look well. So then we start reading between the lines. So what we do, maybe 24 hours later or 48 hours later, we just repeat and see. The repeat also comes like, the CBC is still within the limit, but then the CRP, which was kind of 0.2, now looks like 0.3. So culture is still negative. Then we start reading between the lines. We see that, clinically baby looks sick. At the same time, the CRP, which was completely negative, has become point just borderline now, though the culture is negative. And the counts, which was like 4,000, has become 10,000 today. but then it is still within limits. If you look at the range, it is still within limits, but we start reading between the lines and we can say that probably this is sepsis, and we try to treat. The second thing is, as I said, when we read between the lines is when we have the strong clinical suspicion. When we for sure know that this baby, yes, this baby is in septic shock going down. So this is not right, though everything looks fine. So we all know that newborn babies sometimes might not mount any response at all. The infection and inflammation will be so overwhelming that baby doesn't mount any response, in which case you won't see any change in any of the blood tests what we are doing. But we do have strong clinical suspicions. So when we start reading between lines, try to use all these tests what I told earlier about in a judicial fashion. So you can mix and match, have some 2-3 combined use. Combination is always better than a single test. So combine 2-3 tests, do it together, and then read between the lines and then treat. The investigations, if they are inconclusive, as I said, or the symptoms are unexplainable from the investigation results what we got. So just to kind of stress my point, I have this just scenarios, just 4 scenarios. With that, I'll end my talk. So the 4 scenarios, just very familiar scenarios for us. But then, we will not have a confirmatory diagnosis of sepsis or septic shock on them. But still, we might have treated, many of us might have treated as infection, just with our suspicion and clinical diagnosis. So we have a term baby here who's hypoglycemic, but the feeds are adequate when we look into it. The metabolic work, what we did for hypoglycemia, all comes out to be normal. We check for hyperinsulinism and other hypoglycemia workup, which comes normal. And the initial septic screen we have done is negative. So this time, what do we do? So we start reading between lines. So baby is still hypoglycemic for no reason. We excluded all the possible other reasons for the hypoglycemia. So the reason which we still cannot exclude is sepsis. Then what do we start doing? So we start on antibiotics. 24 or 48 hours later, we repeat the investigations and see. So at that point, if you see a minor increase in something as compared to your first results, then still you confirm probably it is infection and then start treating. Or if the baby starts improving after the antibiotics, looks very well, then probably we would continue. So here we are going to just read between the lines, not stick on correctly to what I said, this is the cutoff or that is the cutoff. So that doesn't apply in such scenarios. The other scenario probably we would have encountered is a stable preterm suddenly has feed intolerance. And if we do all investigations, we suddenly see a little bit of thrombocytopenia, mild hyponatremia, the counts look normal, CRP is still negative, cultures don't grow anything. So our antennas would be up as neonatologists, probably will be thinking maybe NEC or maybe like early infection. So kind of we start treating like that. So get an abdominal x-ray, serial x-rays done. So till we are sure that this is not the cause. So we are putting things together. So this is like again reading between lines. So baby who was fine, why should the platelet count previously last week what we did was fine. So why should it suddenly drop now? So what happened? Something happened. So why the sodium which was normal all this time should drop now? Baby is on the same feed, same fluid. So why that? So we are putting 1 + 1 together and reading between the things, because CRP, as we all know, may not come positive even if there is infection in the first 24 to 48. That's only for prognosis. And cultures, as we know, less than 50% positivity. In NEC, we may not get positive cultures as well. So when we look at the stool, we can even do a stool calprotectin, which is kind of more sensitive compared to just stool occult blood and abdominal X-ray. So we are going there. So we are reading between lines here. So another baby operated for duodenal atresia suddenly has fever and feeding issues. The baby was previously fine on day 1 of post-op, and day 2 today, and suddenly baby is developing fever. And when we do bloods, there is a mild elevation in CBC and CRP, but not so significant, because CRP can be high. As I said, post-op baby, the CRP will always be positive. So we do not know whether it is because of infection. Surgeon will be convinced that it is probably because of the surgery itself. We probably need not be worried about fever. Then what we start doing here? So we again have to start reading between the lines. So the CRP is positive, maybe because of the surgery. So what we can do is we can do a procalcitonin here and see that whether that is positive or not, because procalcitonin generally, as I told you, is not affected by surgery or tissue damage. So because of which, if that comes positive with fever, so we may still think maybe post-op infection or wound infection, and we can start treating. So one last scenario, very relevant to the current scenario. So we have a borderline preterm 36-weeker. We know that 36-weeker are not going to be handful as compared to a 27, 26-weeker actually. So this baby, good weight, maybe 2.4, 2.5 kg baby, suddenly has respiratory distress after birth. So we know that it's not going to be a severe RDS and progressively desaturating and becoming hypoxemic. So on ABG also it is confirmed that there is hypoxia and there is a lot of desaturation going on. You have ventilated adequately. You given enough pressure, enough everything. Chest X-ray is not so suggestive, not bad at all. So if it is not that bad, then we are not dealing with RDS. Obviously, we have done an echo. So I would say like there is no congenital heart disease. There is no PPHN, which is happening. And baby didn't have any other risk factors like say meconium or PROM or anything. And investigations we have sent, so our CBC, CRP, none of them are very suggestive. So in this scenario, so one test we would do probably would be, I would again insist, in the current scenario, one test we would do would be PCR for COVID or a rapid test for COVID, because the mother might have come in and delivered immediately. Her result may be pending. She might come positive after 2 days. By then it will be too late. If the baby is kind of stormy course within 6 hours, deteriorating very badly, not accountable by any other illness which is kind of obvious, then we have to think of corona in the current situation and probably go there and start treating it as COVID positive baby. I hope I just did some justice for reading between lines and for the lab results. And thank you for patient listening. Thank you all.
Thank you, Dr. Parimala. Wonderful presentation. I'm sure we'll have a lot of doubts and it's very practical presentation. The case scenarios were really good. We will move on to the next session. After that, we'll take up all the questions regarding the presentation by Dr. Parimala. Dr. Nandini?
Yeah. Am I audible?
Yes, very clear, very clear. You can start sharing your slide.
Now I am not able to share because it's not highlighting there. Can I be given that access?
Yeah. Prashant Singh, can you make her a presenter?
Yes, sir. 1 second.
First of all, I'd like to apologize profoundly to everybody for the delay. Despite having a trial run a couple of hours ago, the Microsoft Teams decided not to team with me, and then it was a bit of an unexpected delay. And I thank Dr. Parimala for having agreed to do her talk before this. I'd like to thank NNF for giving me this opportunity to talk about this important, simple topic, but yet very important. I'd like to first say, so I can share my slides now. I'd like to first say that oh, just a moment. It's not opening again. Teams is really not teaming with me.
No problem. Just you select this slide.
Yeah.
It will take time. It will take a couple of seconds to minutes.
Yeah. Okay. I think is it visible now?
Yes, it's coming. Yeah.
Oh, okay, good.
Slideshow. Yeah.
So,
slideshow mode. Yeah. Yes.
Okay. So what I'd like to mention first is that this talk now is going to be very basic. It's meant for only those who are not doing ultrasound, who would like to start performing ultrasound, point of care ultrasound. And those who are already doing it might not find this talk much interesting. So that's a disclaimer. Now, point of care ultrasound is a physician performed, so it's not by a radiologist, not by a cardiologist. It's a physician performed goal directed bedside ultrasound examination. So you're actually looking for something. That's why it's goal directed, and it's at the bedside. So you're performing by the bedside of the baby. It's to answer a specific diagnostic question. So you would either look for something like, say, IVH or say PDA or something like that. And it's also to guide performance of an invasive procedure if you choose to do one. Now, I'd like to mention that point of care ultrasound has become part of the components of newborn examination. It's included as part of newborn examination because of the availability of portable machines, the ultrasound machines, which are easily accessible, safe to use, and the information obtained from these examinations is enormous for the minimal effort that you put in. A lot of people have started doing the point of care ultrasound now in all the countries across the world. I'd like to mention about some of the publications. There are several publications, but some of the notable ones are mentioned over here. So the European point of care ultrasound group has spoken about some evidence-based guidelines that they have published recently. I'll talk about it in the next few slides. Then you have the Canadian Pediatric Society, which has put up a position statement in a publication recently, as recent as last month. This is about the cranial ultrasound. And you have a US group which published point of care ultrasound. They have actually spoken about how neonatologists across their country have started doing point of care ultrasound and how they need to bring out evidence-based guidelines, which other countries have already started doing, like the European based guidelines, which I mentioned earlier. And we have some Indian publications published by Pune group, and this was about point of care ultrasound, which looked at cranial ultrasound, lung and gut ultrasound, line localization. And there is also a survey of point of care ultrasound uptake in the Indian NICUs. I'll talk about that after the next couple of slides. So there is plenty of publication going on. So a lot of people are now doing the point of care ultrasound rather than relying on radiologists and cardiologists to do the ultrasound for their patients. Now, talking about the European Society of Pediatric and Neonatal Intensive Care, the guidelines put forth by them, about 41 recommendations were presented, and the panelists had strong agreement for 39 of them and disagreed for 2 of them. And this includes various things that can be looked at the point of care ultrasound. So it includes the cranial ultrasound, it includes the functional echo, it includes lung ultrasound, abdomen ultrasound for various indications. And I could not actually put all of them in one slide. This is actually a large table. All the 41 recommendations are there. And if you look at the third part of that same table here, it shows number 30 and 31 and all those. The cranial ultrasound, which I'm going to talk about after this, how to detect germinal matrix hemorrhage and IVH in neonates, and cerebral blood flow and various other indications. Now, I mentioned earlier about the survey of the point of care ultrasound uptake in the Indian NICUs. Now, this was published recently. It was actually a survey conducted about 3 years ago, and about 148 teams responded. 78% of these teams had access to POCU, they said. And of these, about 97% of them were performing cranial ultrasound. About 90% of people were doing functional echo, but only about 2/3 of them, so about 67% of them were doing point of care ultrasound for evaluating line position. And only 1/3 of them performed lung and abdomen ultrasound. This was about 3 years ago. So since that time, I think more and more people have started doing lung and abdomen ultrasound also. The reasons that were given for not doing the point of care ultrasound, according to this survey, were either absence of expertise or absence of training, strict PCPNDT Act, which is very important. I'll just mention a little briefly about that. Then availability of radiology and cardiology services. So they had access to radiologists and cardiologists, so the people chose not to do point of care ultrasound. That was about 1/4 of the respondents. And then inability to afford the portable ultrasound machine. I think probably that should not be a concern because it's not that unaffordable. Nowadays, I think for about 3 to 5 lakhs, you should be able to get a good portable ultrasound machine. Now, with regard to the PCPNDT Act, this act was actually put forth in 1994 to curb the practice of female feticide by prohibiting the prenatal sex determination. But relatively minor deviations from this also are unacceptable, and any little violation like not maintaining records properly, or if not, you don't have a copy of the act in the place where the ultrasound machine is, or using more ultrasound machines than the number that are registered in that particular place, or not displaying a copy of the registration certificate, all these attract a penalty or fine or even imprisonment. Even in these ultrasound workshops that are conducted, every single ultrasound machine that is used needs to be registered, otherwise they can penalize people. So it's very important to make sure that you take care of this registration and whatever needs to be done legally in order to start learning and practicing point of care ultrasound. Now, coming to a bit of basics, we know that beyond 20,000 hertz, it's called as ultrasound, the wavelength of sound beyond 20,000. But the medical ultrasound machines use between 2 and 15 megahertz. Ultrasound waves are emitted by piezoelectric crystals, which are transmitted by the transducer. These are what transform the electrical signals to mechanical vibrations and vice versa. So the ultrasound waves are reflected back from various body tissues to the transducer and relayed to the machine, and that creates an image which is then analyzed. So acoustic impedance is what determines the brightness or darkness of the image. The denser the material, the brighter the image. So bones appear whiter and fluids appear darker. Air tends to reflect the ultrasound beam, hence it does not allow to visualize structures behind it. Now, I was curious to know what the ultrasound gel contains because it wasn't actually mentioned anywhere, so I looked up. It contains etherified hydroxyethyl cellulose, benzalkonium chloride, which is an antimicrobial agent, 1,3-propanediol, which is a solvent, and water, of course. So this is some important information for those who wish to start doing ultrasound. Remember that the higher the frequency of the probe that you use, the better the resolution, but the lower the penetration. So you will be able to see superficial structures better. The lower the frequency of the probe that is used, the lesser the resolution or the poorer the resolution, but the penetration is better, so you will be able to see the deeper structures better. So with the 7.5 megahertz transducer, you will be able to see parietal white matter, but the more superficial subcortical white matter is seen better with a 10 megahertz probe, and basal ganglia, which is a little deeper, is seen better with the lesser frequency. So 5 megahertz probe would work better. Now, curvilinear and sector probes are used for cranial ultrasound, and linear probes for the other organs like the chest and abdomen organs, and line visualization, spine, joints, venous Doppler, and soft tissues. Now, the modalities in ultrasound machine are the 2D views, which are the basic ones. It has interrupted transmission of waves, helps in structure and orientation visualization. And you have the Doppler, which has continuous transmission of waves, so it helps in looking at the blood flow in the blood vessels, the direction of flow, the velocity of flow. And you have the M mode, which interrogates the tissue along one plane over time. This helps in looking at contractility and the measurements of the wall thickness, etc., especially in functional echo. Now, coming to cranial ultrasound scan itself, we look at the indications for cranial ultrasound scan. This ultrasound performed in preterm babies, the indication would be those preterm babies who are less than 1,500 grams and less than 32 weeks. So in those who are extremely preterm, on day 1, the ultrasound needs to be performed, repeated on day 3, that is within the next 48 to 72 hours, because the chances of IVH are very common. within the first 3 days of life, and it is repeated after a week, and in the next month or so. So within the 36 weeks to 40 weeks corrected age, the ultrasound needs to be repeated. So that's that's the protocol for repeating a cranial ultrasound scan in preterm babies to screen for intraventricular hemorrhage. Now, in the other indications would be if there is a sick preterm with a sudden drop in the hemoglobin, or if there are neonatal seizures which occur and you don't know the reason, you've ruled out other reasons. If there is a rapidly enlarging head, or evaluation for microcephaly, or if you have proven or suspected meningitis or ventriculitis, serial follow-up of post-hemorrhagic hydrocephalus, you're measuring the ventricular indices. And in HIE, in those babies, you would need to prognosticate by measuring the resistance index. I'll mention a bit of about resistance index a bit later. If there has been a traumatic or a difficult delivery, then you would want to see what is what's happening in the scalp or in the head. In sick infants, irrespective of the gestational age, it would be wise to do a head ultrasound. If there is a large boggy swelling in the scalp along with anemia, then you would want to see if there is a bleed. And if there is an unexplained congestive cardiac failure, especially if you have some AV malformation, then it is wise to do. But the most common indication, since we are going to begin doing ultrasound, this talk is about beginning doing cranial ultrasound. Let's focus on the IVH in preterm babies. Now, there are certain grading systems for IVH for periventricular hemorrhagic infarction and periventricular leukomalacia. There are names are mentioned. Now, Papil's grading system is the commonest that is used for intraventricular hemorrhage. Grade 1 is the geminal matrix hemorrhage located in the caudothalamic groove. Grade 2 means the blood has filled the ventricles. And grade 3 means that there is ventricular dilatation along with the hemorrhage. So there is some enlargement of the ventricular cavity. Grade 4 means that there has been some parenchymal extension of the bleed. So grade 1 and 2 have good prognosis, whereas grade 3 and 4 have bad prognosis. Now, periventricular hemorrhagic infarction, there is a Basson scoring system that has been published. This is based on the maximal size of infarct or the territories involved, whether it is unilateral or bilateral, whether there is presence or absence of midline shift. And the scoring is from 0 to 3. Evaluation done is for neuromotor, visual function, and developmental evaluation. Higher the scores, greater are the chances of microcephaly and abnormalities in the gross motor, visual, receptive, and cognitive functions. Now, periventricular leukomalacia grading goes like this. Grade 1, there are transient periventricular areas with increased echogenicity, or what is called as flare, a periventricular flare, for 7 days or more. Grade 2, there are small localized frontoparietal cysts. Grade 3, there are extensive periventricular cystic lesions. And grade 4, areas of increased echogenicity in the deep white matter also evolving into extensive cystic lesions. Now let's come to the actual performance of the point of care ultrasound itself. What are the prerequisites? You need to wash hands thoroughly, make sure that we do not cause any more harm. First of all, do no harm. So wash hands thoroughly to make sure that complete aseptic procedure is followed. Stabilize the position of the baby's head so that it avoids any movement, and if need be, you can ask one of the nurses to help by calming the baby by either using a gauze or dextrose gauze. If the baby is an extreme preterm baby, it's good to use the portholes if the baby is inside the crib, rather than opening the crib and allowing the baby to become hypothermic. First of all, palpate the anterior fontanelle so that you know where you're going to put the probe. And then make sure that the ultrasound gel is a bit warm rather than using cold gel on the baby's head to avoid hypothermia. So while holding the probe, it's good to use your medial 3 fingers to stabilize the head, and the thumb and index finger to hold the probe. So I'm not sure if I'm visible. Prashant, am I visible? Prashant?
Yes.
Okay. So I'm just, if I am visible, I'd like to just show that you would hold.
You can just click on your video down. I request all the participants just to click on the video of Dr. Nandini. then the presentation will go down and the video will come up. Now you can show.
Okay, so when you're holding the probe, it's good to hold the probe this way. Make sure that you stabilize. If that's the baby's head and that's the probe, you make sure that you hold the probe with your 2 fingers and stabilize like that.
If you are unable to see, you can hold it near your face. The probe, you can hold it near your face.
Okay, okay. There, yeah. Okay. So if that is, okay. So if that is the baby's head and that is the probe, then you make sure that you hold the probe with your 2 fingers, your thumb and index finger, and use your other 3 fingers to stabilize the probe and the baby's head so that the probe moves along with the baby's head. So if the baby otherwise moves, then your probe will move and your view will go out of focus. I hope that was clear. Transducer care. Now the transducer needs to be cleaned with the recommended solution or wipes only. It's best not to use any alcohol based cleaning solution because that can damage the transducer. It's best to follow the manufacturer's guidelines, and it's best not to use any paper or paper products because that can also scratch the transducer lens. And always clean the transducer and the cable before using for any point of care ultrasound, and of course between patients, because we would not want to spread any infection from one baby to another if any. Now I would also like to show about certain movements, certain standard movements of the probe which people should know about before starting to do ultrasound. So again, if you are able to see, I hope this is visible. Now, if you're holding the probe like this movement is called, and if this is the baby's head and this is the front and this is the back, this way when you move, this is called angulation. So angulating anteriorly, angulating posteriorly. This is rotation of the probe, and moving sideways, this is a tilt. This movement is called tilting of the probe. And of course, this is sliding anteriorly, sliding posteriorly or sideways. Hope that was clear. Now, as regards orientation of the probe, now there are certain views for which you need to orient the probe in a certain way. Now, for the cranial ultrasound, as a standard practice for the coronal view, the pointer, if you can see, this pointer that is there on the probe needs to point towards the right side. And correspondingly on your screen, you can see that there is a V. The V shows up on the right side. So you know that that is the right side of the brain. So the side where the V is the right side, and the side where the V is not there is the left side of the brain. Okay, so for functional echo, the pointer will be pointing towards the left side of the chest. Now, if the pointer is pointing anteriorly, this is in sagittal view, then you know that that side is anterior. So you have the V pointing towards the left side of the screen, that is anterior, and the other side is posterior. So coming to the standard cranial ultrasound views, we have the coronal views, sagittal views, and axial views. Now, I just want to show the keyboard of an ultrasound machine. This is a Vivideye keyboard. The Vivideye is a good ultrasound machine. There are others also like Sonosite, etc. But this is the one that I use. So I just want to mention about a few things that people need to know about before they start doing ultrasound. So once you turn on the machine, you have this power on button over there, and you have to enter the patient details over here. Always, if you're going to store the images, make sure that you store it under the patient's name and ID, etc. So enter the patient details after clicking on this button here. And then the application, once you click on application, the probe that you have connected shows up, the frequency shows up, and what ultrasound you're going to perform. You need to choose which you're going to perform because it may show up as echo, it may show up as cardiac, it may show up as cranial. So neo head means that you're going to perform the cranial ultrasound. So you choose that. And then the review is to look at the images that you have already stored. Then once you have started doing the ultrasound, if you want the image to be stored, you first freeze over here and then save. Then you have certain other buttons. If you want to increase the depth, make the image a little bigger and go deeper, you have this button called depth over here. To make the image a little brighter, you have these to increase the gain. And if you want to measure something, if you want to do some measurements, like say ventricular indices, if you want to measure the ventricular indices and keep track of the size of the lateral ventricles, then these are the calipers that you need to, this measure button needs to be clicked on, you'll get calipers, you can do the measurement. And to store images, you have the store button over here. And I think as you start doing, you will be able to figure out. Now to start doing ultrasounds first, this 2D, this button that is highlighted in green, that is what turns on first. And let's go ahead. Right. So for coronal views, the transducer is placed with the pointer pointing towards the right side. And these are the different coronal sections which you can see, you can different coronal planes that you can view. This is the first coronal plane. When you look at this image, you can see that in the center there is this linear image of the interhemispheric fissure. Then you have on either side the frontal lobes, and then the bright orbital ridge, and then the orbit below that. So this is anterior to the lateral ventricles. Now if you move, if you angulate the probe a little posteriorly, and you get the second coronal plane, you will be able to see the anterior horns or the frontal horns of the lateral ventricles. So the little slit-like structures on either side, these are the anterior horns of the lateral ventricles. In the center, you have the cavum septum pellucidum, and on either side below the ventricles, you have the basal ganglia with the caudate nucleus with the globus and pigment. And below that, of course, the sylvian fissure, which is clearly visible in this image over here. And below that, you have the temporal lobes. This is another image which shows the same thing. So you have the slit-like lateral ventricles and cavum septum pellucidum in the center. Now, if you angulate a little more posteriorly and get the third coronal plane, you will see that this is the most important plane that all of the ones who are starting to do ultrasound need to focus on, because this is the image in which you'll be looking for bleed, geminal matrix hemorrhage. So here in this image, you will see the third ventricle show up and the lateral ventricles entering into the third ventricles through the foramen of Monro. So you have again all the structures seen previously. You also see the third ventricle, and in some good images, you will be able to see the foramen of Monro. And then if you see this clear, this bright image over here near the medial side of
terminal matrix.
that's the terminal matrix. Yes, that's the choroid plexus, and that is where you would see bleed if it occurs. And the bleed would be almost as bright or a little brighter than the choroid plexus. So if you angulate a little more posteriorly, then you see the trigones or the posterior part of the lateral ventricle. So that is the choroid plexus within the posterior part or posterior horn of the lateral ventricles. And that's another image of the same thing. And this is posterior to the posterior part of the lateral ventricle. So you have the white matter here, and you would have the occipital lobe over there. Right. So that was about the coronal views. Now coming to the sagittal views, the pointer should be pointing anteriorly, and these are the planes that you would be interrogating. So the midline view, and then the parasagittal, and then a little more lateral to that. So this is the midline view, and in the midline view, you would be able to clearly see two bright lines, two parallel bright lines. That is the corpus callosum. And then you have the cingulate gyrus. If it's clearly visible, that's good. And then you have the midbrain below that, and the cerebellum. So what is striking is this lady in a dress sign, as typically described in a lot of books. If you see this image that looks like this, that flares up over here, this is, if this is seen, that is the midline. So then you have the third ventricle and the fourth ventricle in front of it, which is a little lighter. So this shines up brightly, the lady in the dress sign. So then this is another image. You can see it clearly, proudly in this. Now, if you angulate a little, laterally, you would need to remember that you need to actually mention whether it's the right or left, because here you don't have that V sign towards the right or left, it's the anterior or posterior. So you need to actually put a text saying whether it's the right ventricle or the left ventricle that you're seeing. So here it's mentioned as right ventricle. So this is the right parasagittal view. So you have the lateral ventricle seen over here, and this is the choroid plexus, and this is the caudate nucleus. So between the two, you have this caudothalamic groove, and that's where the geminal matrix is located. And the grade 1 or the geminal matrix hemorrhage first shows up over here. So it's brighter over here when there is a bleed. This is a tangential or a little more parasagittal view, lateral to the lateral ventricles. So if there are any cystic changes, they might show up in this view, apart from the other parasagittal view. Now, apart from the coronal and the sagittal views, we have some axial views, which include the temporal and the mastoid views. This is to look at the third and fourth ventricles. If you would like to do measurements of the third and fourth ventricles, especially when there has been some hydrocephalus increase in the size of the third and fourth ventricles, these views can be used. So the way to hold the probe for this is with the pointer pointing towards the right side of the forehead, if you're doing on the right side, and on the temple. And the third and fourth ventricles show up in this manner. So you have the lateral ventricles on either side, you have the cavum septum pellucidum, you have the third ventricle, and behind that the fourth ventricle. There's a little bit of fallout here because the gel is less. So that's one of the reasons why you would have a blackening or a fallout like that. So this is another image that shows the way it is done. So this is a mastoid view, and again you would be able to visualize the third and fourth ventricles in the mastoid view as well. The third ventricle width can be measured with these views, and the fourth ventricle width and length also can be measured. This is useful for monitoring when there is hydrocephalus. Now coming to some extra information here. So Doppler studies are done to look at the cerebral blood flow. And first of all, we need to know what it looks like when you're doing the Doppler. So when there is blood flow towards the probe, it looks red. And when there is blood flow away from the probe or the transducer, it looks blue. So we'll look at some of the images after that. But cerebral blood flow, what we are focusing more on is looking at the resistance index to see whether the flow is good or not. So the resistance index can be calculated by the peak systolic and the end diastolic velocities. The most of the machines actually calculate and give the resistance index already. But if you just get these velocities there, you can calculate by using the formula peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. The arteries that we look at are the anterior cerebral artery, middle cerebral artery mainly. Of course, you can look at the other ones like the basilar and the posterior cerebral also. Now, if you want to look at the arteries, if you want to do a Doppler, first of all, you need to click on this CFM or the color flow mode. So then what you will see is this box that shows up, within which you will see a lot of these the colors light up. So here what we're seeing is the anterior cerebral artery that is curving around the front of the lateral ventricle and moving posteriorly. So since the blood is moving towards the probe is over here. The blood is moving towards the probe, that's why it's looking red in color. Then the next thing you would want to do is to put in pulsed wave Doppler. This pulsed wave Doppler, you can click on that, and what shows up is this. So you'll need to adjust the gate over here. Once you start doing it, you will be able to figure out how to do it. Once this opens up, this gate needs to be parallel to the direction of this flow in the artery. Otherwise, you may get slightly different numbers over here. So this pulse wave or this this will show up, and you will have measurements of your peak systolic velocity, that is up there, and end diastolic velocity down here. If you calculate based on this, the resistance index in this particular baby in this image is about 0.73 or so. Now the resistance index varies from 0.6 to 0.9. If it is less than 0.6, it is abnormal, seen more so in babies with HIE and perinatal asphyxia, and it's raised in many other conditions like bleed and the various other conditions. So if it's more than 0.9, it is abnormal. Then you have the middle cerebral artery that is clearly seen in this Sylvian fissure over here in the coronal view. Now, okay, now coming towards the end of my presentation, the take home views would be, you make sure that you know the anatomy well. When you put the probe, you need to know what you're looking at. So make sure that you familiarize yourself with what you're looking at before you are able to identify abnormalities. Know the terms tilt, angulation, rotation, and sliding of the probe to understand how to move. In case you're doing it and somebody instructs you to move the probe in a certain way, you'll need to know how to do that to optimize your image. The anterior fontanelle is the main acoustic window, but you can look at the axial views through the temporal bone and the mastoid views also. Remember that the choroid plexus has increased echogenicity and it may be mistaken for bleed. The most important precaution that we need to take is regarding hand hygiene, more so in the current scenario. We have to make sure that we do not cause any problems to the baby. It's most important to avoid sepsis. Transducer gel also should be sterile and stored at room temperature, but preferably warmed before doing the ultrasound. Remember that a 7.5 megahertz probe is most useful for all the images that you want to get, to look at the superficial structures, to look at the deeper structures also. But remember that a higher frequency probe is useful to look at superficial structures because the higher the resolution and the lower the penetration, but you can look at superficial structures better. And with a lower frequency probe, you will be able to see the deeper structures better because there is greater penetration, although the resolution is lower. So that, I think, brings me to the end of my presentation. Thanks. It was a very simple presentation aimed at those who want to start doing cranial ultrasound.
Thank you very much. Wonderful presentation. I think all the basic information required to start neonatal neurosonogram has been covered comprehensively. Thank you very much for the wonderful presentation. So now we'll move on to the discussion part. I think few questions I've already posted here in the chat. First to Dr. Parimala. Dr. Parimala.
Yeah. Shall I start? I was going through the questions as well. So I will. Can I start with the score first? So
please.
Yes, actually. Can you hear me?
Yes, we can hear you very clearly. Please go ahead.
The questions are really relevant, very important. I would like to stress that I didn't go into detail with each and every kind of.
Parimala? Can you mute
Prashant?
Investigations which I mentioned.
Can you mute all? Sing once. Sing.
Done, sir.
Kindly unmute Dr. Parimala. Yeah, Dr. Nandini, you can unmute. Kindly unmute yourself. Yes,
Yeah.
sir. Dinakar, sir. Yes, sir.
Yeah. Dr. Nandini, excellent talk. Really good, eye-opening, and you have told everything. And whatever the necessary things, point of care ultrasound, what is real necessary for neonatologist, what we should do, what we should see. You are told excellent. And Dr.
Thank you.
Parimala, as usual, were really, really excellent. And Dr. Parimala, as usual, very good talk. Very good. But so many questions are there. I think so. Even Prashant Goda got some WhatsApp messages also to ask the questions. I don't know why the people have not posted here. And I think so, Prashant, you are telling you only ask, my dear.
No,
I think so.
Sir, I posted. She's about to answer now, sir. I posted the question
Okay,
to
start.
her.
All the best. All the best.
Yes. Yeah. Please
Thank
start.
you, sir,
Dr.
actually for your encouragement. Thank you very much for your encouragement. In fact, like I think I get into all this forum because of you. You just kind of put my name there and I'm there. So thank you again. To start answering the questions, yes, septic score is important. It's very significant. Anything more than 2 is kind of significant. And the total count, differential count, and the immature neutrophil ratio, and that never goes out of picture. So like old is gold, that is something which we still have to hold on to, because that is one of the thing which is very, very suggestive of sepsis. And IT ratio, yes, though we do it from very long time, for many years together, it still stands as one of the strong kind of supportive result report for sepsis. So IT ratio also is equally important. And regarding the question about that salivary CRP, IL-6 and procalcitonin, all of them are very significant, because when I said secretions, I think I did not mention saliva. That is the newest thing which is coming. So you don't want to prick the baby, we can take the saliva, we can do PCR from saliva, especially even for corona. So like that, yes, salivary PCR, IL-6 and procalcitonin is a good combination as well. So this doesn't put our other septic score into the backdrop. That also is a good score. This also is a good score. So just I would give an example. Individually, if you want to make a difference to the babies, we can't. But collectively, we all together, like in the forum, like NNF or something, we can make a difference. So like that, all these markers individually may not be so important. But when we put together and we have a score, yes, they have more specificity and sensitivity. And going for that steroids, you had asked, like, steroids in sepsis. That is the reason I showed that pathway of sepsis. In the initial stage where the pathogen is just entering the body and body is trying to fight, that is not the time for steroid. But if the inflammatory markers have started coming and it is going, the cascade is going on without any inhibition, that is the time, yes, steroid will help. Even immunosuppressant may help, that is in the future. But even for corona, we are seeing that, steroid comes at the stage 2, 3, and then immunosuppressants also come in. That's because of the inflammatory cascade. And regarding the question about NEC, whether there are any other tests, I did mention actually that stool calprotectin is very sensitive. So in spite of all the stool for blood and abdominal X-ray and all that, calprotectin, if it is positive, that is more sensitive for NEC. And as you have mentioned, breath test, somebody had mentioned about breath test. Yes, the hydrogen, if you can detect in the breath, within 24 hours actually. So even before the NEC symptom starts, even before the baby shows us the symptoms of NEC, the bloods and other things, if you can measure the hydrogen in the breath, that is the breath hydrogen test, if it is positive, yes, that is very much a predictor of NEC. So we have to be careful, and that baby may be going in for NEC. And this is as early as 8 to 28 hours before the onset of NEC. And for COVID, somebody had asked what is the current treatment, whether steroids and other things in the very first beginning. No, I would say you go by stepwise. So if the baby is little asymptomatic and not much of problem, so you still go with zinc antiviral and antibiotic as of now, with symptomatic treatment like paracetamol. So the steroids will come in picture only when the CRP starts increasing, procalcitonin starts increasing, the inflammatory markers start going up. That is when you include the steroids in your treatment. And if the IL-6 is getting totally out of control, so at that point, even immunosuppressant like tocilizumab, that also comes into picture. So this would be the order of treatment in COVID. I've just simplified. It's a big thing according to what stage, everything. So I've just simplified it for you. I hope I've answered. And I think one question about vertical transmission, how early we can detect. So this is the reason I said the newer test, this is where they come into picture. So we have the old test, we know sepsis and all that, but we need a lot of time to confirm through old test. But the newer test, as I said, that IL-8, which I said, can be raised even before the CRP, before any response mounts in the baby. So as early as 2 to 4 hours after birth, we can detect vertical transmission and sepsis because of vertical transmission if we can measure IL-8. I think I've answered all the questions.
Yeah. Thank you, ma'am. Thank you.
Welcome, sir. Thank you once again.
Yeah, I think few questions.
Can I ask?
Doctor,
Sir,
sir?
Can I ask one question?
Yes,
Can I
sir.
ask?
Yes. Please, sir.
This test, CRP, CBC, anyway, we should do it immediately after birth, or we should delay the test? CRP, CBC, whether it should be done immediately after the birth or should be delayed?
It should not be done immediately after birth. We should delay. Ideally, if we do it after 2 to 4 hours after birth, the first reading, that would be better. The CRP is not going to be of use if we do it immediately. But the thing is, it would serve as a baseline. So the first day, if you do a CRP, and then the next day or following day when you're repeating, if the CRP is on the increasing trend, that is when it comes into picture. Just a positive or negative CRP on the day one has no value at all, because as far as we know, in the first 24 hours, it's going to be negative. It is not going to be positive. And as we know, immediately after birth, as we know, like the babies are going to have very high leukocyte count, and the maternal thing would be reflecting. That's why we don't do even the renal function test and all immediately, because the mother's urea creatinine will still be reflecting on the baby. So all these are better if we start doing after the first 4 hours of life. But then, as I said, if you want to know something before 4 hours, we have the newer test like the IL-8, IL-6. And
Madam, is there any significance of finding eosinophilia in neonatal CBC?
Yes, sir. As a given, as a PG, we used to do the gastric aspirate and we used to look for eosinophils also along with neutrophils. So it does have significance, but only thing is it is not currently under the septic scoring and currently under the septic screening as a part of test. But if you are getting it, yes, it does significant.
In my experience, I'm getting it in the cases of fungal sepsis, and it is also mentioned that the eosinophil count may get raised due to the antigen present in the fungal itself. So,
fungal and parasitic, both the eosinophil count can be high. So any parasitic infection, if you're suspecting, or fungal infection, the eosinophils are more useful as compared to the neutrophils. And same, sir, viral, it's lymphocyte, bacterial, it's neutrophils, usually eosinophils in fungus and parasites.
when we should repeat the test to find out the improvement in the sepsis?
Any antibiotics will take 48 hours to act. So if you want to really kind of want to know whether the child is improving, I would suggest after 48 hours we can repeat. But if the child is deteriorating, then it depends. It depends on the your clinician's instinct. So if you want to know if it's going down, then you can repeat immediately also after 6 hours, after 12 hours, after 24 hours, depending on the baby's condition. But if you want to see improvement, you have to give 48 hours time for the antibiotics to act, and then repeat after 48 hours would be ideal.
What is the cost of the recent test you have told to us? Cost of the test.
So honestly, I'm not sure. So actually, I don't know the cost of the test, but I can find out. I can find out and let you know.
Okay. Thank you very much.
Thank you.
Thank you, sir. Thank you, sir. Now, I think we have few questions for Dr. Nandini. Are you able to see? Yeah.
I think you have posted some questions. Yes, I can see how to adjust gain to get good quality image. There are some knobs to move on this keyboard that I had displayed earlier. It's similar kind of knobs would be there on all the portable ultrasound machines to adjust the gain. Well, that's what I can talk about that. What is the importance of supplemental window? By supplemental window, if you mean another screen on the ultrasound machine screen itself, is that what you meant?
No,
you can have
he was asking about PF, temporal window, mastoid window.
Okay. So So those, see, that is axial view. Apart from the coronal view and the sagittal views, you have the axial view also. That is to look at the third and fourth ventricles. So the importance of those views, axial views, is to measure the size of the third ventricle and the fourth ventricle. Those are important when you are trying to look at the prognosis in babies with hydrocephalus, with say post-hemorrhagic hydrocephalus, when there's enlargement of the all the ventricles and including the third and fourth. So the sections, I think the next question also is regarding the same thing. Which section should we take? So the probe needs to be placed in the temporal, on the temporal bone over here, as I showed earlier, and behind the ear on the mastoid. So those two views will give you the axial views, third and fourth ventricles. Someone has mentioned that they find it difficult in getting complete lateral ventricle length in the sagittal view. How to get good quality image? The reason may be, I can think of a few different reasons. One may be that the gel is not, there's no proper contact with insufficient gel along the whole length of the lens of the transducer. That's one thing. So you need to make sure that you have enough gel. Two, it could be that in sometimes curvilinear probe gives you better images. Sometimes linear, not the linear one, the other one, the sector probe gives you better images. So you'll have to find which one you're comfortable in with and which one you're able to get good images in. The other thing you should remember is a slight angulation may be required to get the midline sagittal view. A slight angulation might be required. So while doing, with practice, you will be able to get the full length of the lateral ventricle in your images. Are there any others?
Yeah. Can neonatologists give reports to patients? Is it legally acceptable?
So those who have registered themselves with the PCPNDT Act, they are okay. They are actually allowed to give reports as long as they have trained themselves in doing the point of care ultrasound. Now we don't have any formal training as such, no certified training courses in India. So those who trained themselves in other countries, they are allowed to give reports. But one of the reasons in that survey which I mentioned about earlier, one of the reasons why many people are not doing the point of care ultrasound is that they are not comfortable legally in actually giving out a report. So they prefer to still get the reports generated by their radiology colleagues.
Yeah, I think these are the few questions. Dinakar sir.
So can I ask one question, sir?
Yeah, please, sir. Please, sir. Please, sir. Please, sir.
Can we get information after the information from the intracranial content? Was the cranial suture has been fused, or after cranial stenosis? In cases of cranial stenosis, was the cranial sutures has been fused? Can we get information from the ultrasound, the intracranial information?
The thickness of the bone is such that you may still be able to get images despite the closure of the anterior fontanelle, even if you have a craniostenosis. Because with a temporal bone, you can actually get axial views when you integrate through the temporal bone. So you might try. I mean, I have not come across any baby with a craniostenosis in which I have performed ultrasound. So it's hard for me to say, but I presume that you will still be able to get some images.
Rather, it is not a good idea to get ultrasound in cases of cranial stenosis.
You can probably try, and if you don't get good images, then you always have MRI as the option.
Thank you.
Yeah. Any of the participants have any questions? They can unmute and they can ask. So the discussion is on. Dr. Dinakar sir. I think he had few questions was sent to him. Anyway, yeah. Dinakar sir? Yeah. It's okay. Yeah, I think these are the questions which I've got. Let me see if I missed any earlier ones. Yeah, this is about the traumatic lumbar puncture. Did you answer, Dr. Parimala? How to?
No, actually, I don't think I answered about that one question. So the traumatic lumbar puncture is a nightmare almost for all. I would say from the most inexperienced to the most experienced, because it really doesn't matter how experienced you are, you can still end up having a traumatic lumbar puncture. But the thing is, how to interpret is again, this is where you have to again read between the lines, I would say. So one thing is you can correct and see. So you can count the RBCs. So based on the RBCs, you can correct the WBC. So you can have a corrected WBC count and see. But still, it will not give you the protein levels and all that will not be reliable, because the blood itself is protein. So that protein level may be high. So you cannot infer as meningitis. So only thing, cell count you can see. If the gram stain, you can always look if organisms are present. They are present actually, whether it is traumatic or not. And the culture. So you have to rely more on gram stain and culture rather than cell count. Cell count, corrected WBC count will still be useful, but not the remaining, not the biochemistry part of it.
I think there is one more question. This is for Dr. Nandini. Which image to take for the Dopplers, the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery? Which section of image needs to be taken?
So for the anterior cerebral artery, it would be the parasagittal view. That's where you would be able to see the anterior cerebral artery curve around the front of the lateral ventricle, curve around the anterior horn of the lateral ventricle. So the parasagittal view is what you would need to use. For the middle cerebral artery, it would be the coronal view. You can see the middle cerebral artery light up in the sylvian fissure. So these are the two major ones, main ones that are seen. For the posterior cerebral, honestly, to say, I have not actually looked at the posterior cerebral. I mainly look at the anterior cerebral and the middle cerebral arteries. So in the coronal view, you may be able to see, but I am not. I have not done that.
Okay. Yeah, I think these are the questions what we had. So if any of the
I ask one question?
Yeah, please, sir. Please, sir. Go ahead, sir. Naresh, sir, please go ahead, sir.
Yeah, yes. Is there a lot of difference between the blood sugar which is done from the hand prick or heel prick, or from the blood obtained from the ETTA vial? Does the sugar value differ in the ETTA vial or the blood which is tested from the finger prick or heel prick? The blood sugar value.
Blood sugar definitely would be different when we do a venous sample and when we do a
Singh, can you mute all and we'll unmute ourselves? Mute all. Yeah. You can unmute. You can unmute and you can answer. Please unmute. Yeah, Dr. Nandini, you can unmute. You can unmute.
Yeah. Okay, done.
And Dr. Parimala, you can unmute, and Dr. Naresh, sir.
Does the blood sugar values differ between the venous blood, arterial blood, or capillary blood, or if the blood sample, blood test is blood sugar done from the EDTA vial?
Yeah, Naresh sir, आप question repeat करेंगे? There is one more.
Sir, my question is the value of the blood sugar, whether it differs from the capillary blood, venous blood, or arterial blood, or even the blood sample which is obtained from the EDTA.
Yeah, Dr. Parimala, can you unmute? I think your voice is breaking, sir. Naresh sir.
Did I answer the question, sir?
Yes, sir. Yes, sir. Please go ahead. Please answer. There are a few questions which has come up. We can answer. Yeah.
I just answered the sugar question. So was it not audible?
No.
No,
It was not audible.
It was not audible. Okay. I said that capillary sugars and venous sample, definitely the sugar is going to be different levels, because if there is a low perfusion and in a septic baby where the perfusion is low, cold peripheries, what levels we're going to get by heel prick is going to be completely different. But venous sample would be more accurate that time. The blood sample would be more accurate as we know. And for your question regarding the EDTA bottle, that's why sugar we should not just take in a normal EDTA bottle, which we do CBC from, because we know fluoride reacts with the blood, and the sugar levels may not be accurate if you take too much of EDTA sample. So it has to be taken in the sugar bottle only. If you're doing it in the normal red bottle, it will be accurate, sir. But if you're taking an EDTA sample, it will not be because of the fluoride.
ICT measurement by optic nerve sheath measurement. I didn't know what. There are a few questions which has come up. What is your experience on BioFire? What is its specificity and sensitivity in neonatal sepsis?
Sorry, I didn't get that question. I didn't hear it properly.
What is your experience on BioFire? What is its specificity and sensitivity in neonatal sepsis? By Dr. Abhijit has asked.
Okay, I would say personal experience, no, like not used much at all actually. But as I mentioned, I've mentioned all of them in part of my topic itself. I mentioned actually they are relevant, and as I mentioned, I didn't go into extensive thing about every single thing because I thought it would become boring. So I mentioned the most common ones which we are using. That is how that hydrogen breath test for NEC. So because individually I did not go into it. They are significant. They are significant.
Yeah. What is the role of gastric aspirate cytology and culture for the diagnosis of sepsis in baby where feeding has already started?
Feeding already started, then it doesn't give us that much of information. But still, even with feeding, baby should not be having too many leukocytes in the gastric aspirates, as we know. Because mother's milk is not going to have that many leukocytes actually fighting cells unless she herself has an infection during the last trimester or she has sensed that baby has an infection. So after feeding is not reliable. So if you're suspecting vertical transmission, even before we give the first feed, if we can aspirate the gastric aspirate and look for polymorph, that's more significant.
Yeah, I think these are the questions what we had. Yeah, if any other questions is there, the participants can unmute and they can ask directly. Yeah, hello.
Hello.
Yes.
Yeah,
please,
Parimala ma'am.
Yes, tell me.
Yes, ma'am. What is your experience regarding use of tocilizumab in neonates?
It is recommended for this COVID thing and also like severe autoimmune this one. But I've used in an older child, not in neonate. Older child who came with autoimmune encephalitis who did not kind of respond completely to everything what we did, including steroids, everything. Baby did not respond at all, kept on having multiple seizures. So ultimately we had to go for tocilizumab. We didn't have much of a side effect. It was quite okay, tolerated well. But in neonate, I haven't used yet. But it is indicated in COVID if they are going into cytokine storm and if the IL-6 is very high, it is indicated. We can use it.
Actually, we had one
no
patient who was COVID positive, and child was post-operative case of tracheoesophageal fistula, and then post-operative child had a very stormy period. Child went into cytokine storm with very high IL-6 and all the inflammatory markers which were prolonged. But unfortunately, at that time, tocilizumab was not into the picture, and we could not survive that child. But I was just skeptical.
Tried steroids. Steroids you tried, no ma'am?
Steroid we tried. We had given steroid in that child.
Because that came in little bit later because they realized the pathology and everything little later only. Initially, we were treating like ARDS. Many were dying. Later, we found out like it's all because of clots. It's not because of ARDS. It's ventilation coefficient mismatch. So now we are giving anticoagulants. So mortality is reduced. So we are kind of learning as the virus evolves. We are also learning. So tocilizumab came recently only. As I mentioned, like asymptomatic, symptomatic. So if we go stepwise, minimal symptom is only still zinc, antibiotic, and antiviral. Little more when the cytokine storm in the beginning, you can still go for steroids. If the IL-6 is very high, more than 10 times higher, that time itself you can give tocilizumab. So I think we are more well equipped compared to before how we were treating.
Thank you.
And I have used it in older babies, not in neonates, but definitely older child, and they tolerated it well. Except for a little bit of fever and rash, baby was fine.
Okay. I have one more question for Nandini ma'am.
Yes.
Ma'am, how can we sterile the transducer gel?
The transducer gel comes sterile. You don't have to sterilize it. It is available in sterile containers. As long as you keep it clean, it would remain sterile. And you have the contents having this benzalkonium chloride, which is actually an antiseptic in the gel.
Okay.
Yeah, so when you use it, you just have to make sure that you don't touch the nozzle to any part.
Exactly.
You will be able to maintain it sterile.
Thank you.
And I see one question mentioned here, the probe frequency to do lung ultrasound in newborn. The frequency would be more than or equal to 7.5 megahertz, and it's a linear probe that is used. In fact, a couple of weeks ago, Dr. Tushar Parikh spoke about lung ultrasound. If anybody has read it, they would know about it. He spoke in detail about lung ultrasound.
Yeah, I think these are the questions what we had. Yeah, that's all I see. One more question. Why do we take only 6 planes in coronal section and 5 sections in sagittal section is what they have asked.
The structures that you see are such that you would be needing more planes in the coronal section rather than in the sagittal. So there are many structures when you sweep from anterior to posterior, when you angulate the probe from anterior to posterior in a coronal plane. So you come across many different structures. So you will need to have those many planes. Whereas in the sagittal and parasagittal, all that you would be looking for is the cordothalamic groove, the lateral ventricles, and the periventricular area. So those sections would be sufficient. Those planes would be sufficient. I hope that's a good enough answer.
Yes.
Excuse me, Nandini ma'am.
Yes.
Hello.
Yeah. Good. Yeah, please go ahead.
So can I ask one question?
Sure.
Does the use of adrenaline or hydrocortisone steroids drastically change the sugar level?
I think that is for Parimala.
Sorry, he said your name, so can I have the question again, please?
Will hydrocortisone sugars? That is
Does
what
the
is
use of adrenaline or steroid drastically change the level of this blood sugar in newborns?
Use of hydrocortisone. Definitely. Automatically the sugar level goes up for the baby. So hyperglycemia is one of the side effect, and sometimes even when we use steroids. So the sudden rise in CRP may be because of steroids that cause hyperglycemia.
Excuse me, Nandini ma'am.
Hello.
Can I ask one question?
Sure.
Yeah. Is it mandatory to do ultrasound, cranial ultrasound below 1.5 kg?
Below 1.5 kgs?
Yeah. Is it mandatory to do cranial ultrasound?
See, it depends not just on the weight, but on the gestation also. If the baby is less than 32 weeks of gestation, then it is mandatory to do cranial ultrasound. And most of the times, these babies who are appropriate for gestational age would be around that weight. So less than 1.5, less than 32 weeks gestation, it is mandatory to do the cranial ultrasound. For those babies who are of a slightly higher gestation and a little higher weight also, if they have gone through a STOMI course in the newborn period in the NICU, then it is necessary to do a head ultrasound for such babies also.
Madam, what is the reason I could not get it that time because of network problem? Why should we do?
For babies, you mean the babies who are less than 1.5?
Below 32, below 32 weeks.
Okay, so for below 32 weeks, what you're basically screening for is intraventricular hemorrhage. Such babies are
If there is no symptom also.
Yes, yes.
Without any symptoms also.
Yes.
Okay. Thank you. Thank you. Thank you so much.
Okay.
I think we have come to the conclusion now. We're going to close the discussion now. Anyway, thank you very much, Dr. Nandini and Dr. Parimala. Wonderful
Thank you so much for the opportunity.
Thank you so much. Thanks for the opportunity again.
Wonderful presentation, and most of the things are very comprehensively covered, very neat, very clean, and wonderful presentation. Thank you very much for that. So have a great evening. We will catch up again this coming Saturday for our session